Okay, so let's dive right in, shall we? We're tackling something really fundamental today, something core to how your body actually works. Imagine like a tightrope walker trying to stay perfectly balanced. Every little shift, every tiny gust of wind needs an immediate, precise adjustment. Well, your body, it's constantly doing that with its acid-base balance. It's this incredibly critical physiological tightrope. And when things wobble even just a little, the effects can be, well, profound.
It truly is a remarkable feat of homeostasis. It really is. And understanding the mechanisms that maintain that balance and critically what happens when they fail, that's just key to understanding a vast number of medical conditions.
That's exactly what we're unpacking today. You shared some really comprehensive source material with us, focusing specifically on this systemic pH regulation and acid-base disturbances. And this isn't about just skimming the surface. Our mission in this deep dive, based on what you've asked for, is to go through this material meticulously, help you really master it, like the elite professionals who deal with these complex scenarios every single day.
Yeah, the source material gives us a really detailed map, a road map almost. We'll explore the normal state, how it gets disrupted, whether simply or, through these complex mixed disturbances. We'll look at the body's inherent compensatory responses, and maybe most importantly, a systematic approach to figuring out exactly what's gone wrong and how to start addressing it.
All right, fantastic. Let's step onto that tightrope then and understand the normal state first. Where exactly is that sweet spot, that target pH the body is always striving to maintain?
Well, the target, it's incredibly narrow, almost.
Yeah.
Astonishingly so, really. We're talking about systemic arterial pH, and it's held tight between 7.35 and 7.45.
Just 7.35 to 7.45. That's tight.
Exactly. A tenth of a pH unit top to bottom. And this extremely tight range is absolutely essential. Why? Because nearly every cellular process, every biochemical reaction in the body, especially enzyme function, it's exquisitely sensitive to the concentration of hydrogen ions. Even small deviations outside this narrow window can severely impair vital functions, sometimes irreversibly.
Okay, so it's crucial. And it's not just one system working in isolation to maintain this, is it? What are the main players keeping us centered on that tightrope?
No. Absolutely not. It's a highly integrated system, redundant even. You've got multiple lines of defense working together. The first responders, the fastest ones, are the chemical buffering systems.
Buffers, okay, like a chemical shock absorber.
That's a great analogy.
Yeah.
Exactly. They can quickly soak up excess hydrogen ions when things get too acidic, or release them if it gets too alkaline. We have them both outside the cells, extracellular buffers, the most important one being the bicarbonate buffer system, and inside the cells, intracellular buffers. They provide immediate relief, but it's temporary. They can't actually eliminate acid or alkali from the body, just tie it up for a bit.
Okay, so buffers buy you some time. Who comes in for the longer game, the more sustained effort?
That's where the respiratory and the renal systems really step up. The respiratory system, which is primarily controlled by your central nervous system, your CNS, regulates the arterial carbon dioxide tension. We call that PaCO2.
PaCO2, millimeters of mercury, right? Representing the dissolved CO2.
Precisely. It's essentially the pressure or amount of dissolved CO2 in your arterial blood. And because CO2 dissolves in water to form carbonic acid, well, changes in PaCO2 directly impact acidity. The respiratory system can alter your breathing rate and depth relatively quickly. We're talking within minutes to adjust that PaCO2 level.
Okay. Lungs handle the fast CO2 adjustments. And the kidneys then? What's their specific role?
The kidneys are the body's slower, but arguably more powerful regulators in the long run. They manage the metabolic component primarily by controlling the plasma bicarbonate concentration, written as HCO3.
And that's measured in millimoles per liter, IMO.
Correct. The kidneys can tweak bicarbonate levels by reabsorbing almost all the bicarbonate that gets filtered through them. They can generate new bicarbonate when needed, or they can excrete excess bicarbonate if there's too much. Now, this process, it takes hours, even days for its full effect. So it's essential for sustained balance and especially for handling acid loads that aren't carbonic acid.
So we've got buffers for the immediate fix, lungs for the quick CO2 tweaks, and kidneys for the long-haul bicarbonate management. It sounds like these two main players, lungs and kidneys, are in this constant dance, influencing each other's work. And you mentioned there's an equation that captures this relationship beautifully.
Oh, absolutely. It's central to understanding acid-base chemistry and biological systems, the Henderson-Hasselbalch equation.
Henderson-Hasselbalch. Okay, let's unpack that. What does the equation actually look like?
The equation is pH pK8 plus log HCO3 IPOCO2.
All right, let's break down those components. pH is obviously acidity. What's pKa?
pKa is essentially a constant for the bicarbonate buffer system in blood. It's around 6.1. You can think of this pKa as the pH where you have equal amounts of the acid form and the base form of the buffer. It's kind of the optimal working point for that particular buffer system.
Okay, pK is 6.1. Then we have the logarithm of a ratio.
Exactly. The log of that ratio, HCO3, the bicarbonate concentration we just talked about, regulated by the kidneys, that's your metabolic component on top, divided by APOC. PaCO2 is the partial pressure of CO2, regulated by the lungs and CNS, that's your respiratory component, on the bottom. The alpha symbol, that's just the solubility coefficient of CO2 in plasma, it's about 0.03. Its job is simply to convert the PaCO2 pressure measurement into a concentration term, so the units match up with bicarbonate in the ratio.
Ah, I see. So the pH is directly determined by this ratio. The metabolic side, bicarbonate, over the respiratory side, CO2 pressure converted to concentration. Keeping that specific ratio right is the absolute key to maintaining that narrow pH range.
Precisely. And the body has these distinct but very much interconnected mechanisms for regulating each part of that crucial ratio.
Let's zoom in on the respiratory side first, the PaCO2. How is that typically regulated day to day?
Well, under normal metabolic conditions, your body is constantly producing CO2 as a byproduct of making energy. This production is usually perfectly matched by the CO2 you excrete through breathing. This keeps things in a steady state, with a PaCO2 typically around 40 millimeters of mercury.
So if I start exercising, producing more CO2, my lungs just automatically breathe faster and deeper to get rid of the extra.
Yes, that happens, but the source material really emphasizes that it's the neural control that's primary here. PaCO2 is regulated primarily by neural respiratory factors. These factors respond to chemoreceptors in your body that are sensing CO2 levels and pH levels in the blood and brainstem. So while yes, increased CO2 production will stimulate ventilation, the actual level that PaCO2 settles at is ultimately determined by this neural control system.
Okay, that's a key point. So if someone's PaCO2 is high, it's usually not because their body is making way too much CO2. It's almost always because they're not breathing it off adequately.
It's exactly right. Hypercapnia, which is just the term for an elevated PaCO2, almost always results from hypoventilation, meaning reduced alveolar ventilation relative to the body's metabolic rate. Conversely, hypocapnia, a low PaCO2, is due to hyperventilation, breathing off too much CO2. So when you see changes in PaCO2, it usually reflects either problems with that central nervous system control of breathing or issues with the actual mechanics of breathing. Or, and this is important, it could be the body's compensatory response to a primary change in bicarbonate level.
Right, the metabolic side. And we mentioned the kidney regulates bicarbonate.
Yes, plasma bicarbonate concentration is firmly in the kidney's domain, controlling how much is reabsorbed, how much is excreted, and critically generating new bicarbonate to replace what's used up, buffering acids.
Okay, so that's the picture of normal. Buffers, lungs, kidneys, all working in concert, finely tuned to keep that pH between 7.35 and 7.45, but managing that HCO3 over PaCO2 ratio. But, as we said, things don't always stay perfectly centered. That tightrope can start to wobble. Let's talk about what happens then. Section 2, simple acid-base disorders.
Right. This is when you have one primary initiating problem throwing things off balance. The source defines 4 simple disorders. Metabolic acidosis, where the primary problem is low bicarbonate, HCO3. Metabolic alkalosis, primary problem is a high bicarbonate. Respiratory acidosis, primary problem is high PaCO2. And respiratory alkalosis, where the primary problem is low PaCO2.
And as soon as one of these happens, the body immediately tries to counter that primary push, doesn't it? That's the concept of compensation.
Precisely. The body's physiological response to a primary disturbance is actually quite predictable. It follows set rules. If the initial problem is respiratory, meaning a change in PaCO2, the kidneys will adjust the HCO3 levels to try and compensate. That's the metabolic compensation. If the initial problem is metabolic change in HCO3, then the lungs will adjust PaCO2 through altered ventilation. That's the respiratory compensation.
And a really critical diagnostic point here that the source highlights is that this compensation tries to bring the pH back towards normal, but it doesn't typically succeed in getting it fully back into that narrow 7.35 to 7.45 range. Is that right?
That's a very important principle to grasp. Compensation helps mitigate the pH change. It brings it closer to normal than it would be otherwise. But usually it leaves the pH still slightly outside the normal range. This is key because if you see significant changes in both PaCO2 and HCO3, but the pH is sitting right there in the middle of the normal range, like 7.40, you should immediately suspect there's more going on than just simple compensation. It's highly likely you're dealing with a mixed disorder, where two primary problems are effectively canceling each other out, at least in terms of their effect on the pH.
Okay. But you mentioned there might be one exception, where compensation could potentially normalize the pH.
Yes, the source points out one specific scenario: chronic respiratory alkalosis. If hypocapnia, low PaCO2, is prolonged, the renal compensation lowering bicarbonate can sometimes be sufficient to bring the pH all the way back into the normal range. This is noted as a pretty unique situation for compensation acting alone.
Okay, good to know that exception. Let's get into the specifics of compensation now. The source provides actual quantitative relationships, like formulas, for how much change you should expect in the compensating variable. Let's start with metabolic acidosis.
Okay, metabolic acidosis. The primary problem here is a drop in HCO3. This can happen either because the body's producing or taking in too much acid, or because it's losing too much bicarbonate, maybe from the gut or kidneys.
And this drives the pH down, makes the blood more acidic. How does the respiratory system try to counter that?
Well, the low pH stimulates chemoreceptors, particularly in the brainstem. This triggers an increase in ventilation. The person starts breathing faster and deeper, hyperventilating. This increased ventilation blows off more CO2, lowering the PaCO2, and if you remember Henderson-Hasselbalch, lowering the denominator of PaCO2 helps raise the overall pH back up towards normal.
Makes sense. And we can actually predict how much the PaCO2 should drop if the compensation is appropriate for the degree of acidosis.
Yes, and this is one of the most powerful diagnostic tools we have in acid-base analysis. The source gives us Winter's equation. It states that the expected PaCO2 equals 1.5 measured HCO3 plus 8 lemon Ag2.
Okay, let's use the example provided in the source material. If a patient's bicarbonate HCO3 is measured at 12 millimole.
Right, so you plug 12 into Winter's equation, that's 1.5, not 12, which is 18. Then add 8, which gives 26. And the equation has that nary 2 wiggle room. So the expected PaCO2 for a simple metabolic acidosis with a bicarbonate of 12 is approximately 26 millimole Hg, with an acceptable range of 24 to 28 millimole Hg.
Okay, so if that patient has a bicarbonate of 12 and their measured PaCO2 is, say, 26, then their lungs are doing exactly what they should be doing. It looks like appropriate compensation for a simple metabolic acidosis. But what if the PaCO2 is outside that predicted range of 24 to 28?
That's the critical insight this equation provides. It flags a potential mixed disorder. If the measured PaCO2 is lower than predicted, say less than 24 millimole Hg in our example, it means the patient is hyperventilating even more than required just for compensation. This strongly suggests there's a coexisting primary respiratory alkalosis driving that extra ventilation. On the other hand, if the PaCO2 is higher than predicted, say greater than 28 millimole Hg, it means the patient is either hypoventilating relative to the expected response or simply failing to compensate adequately. This points towards a coexisting primary respiratory acidosis complicating the picture.
Wow, okay. So Winter's equation is like a diagnostic test for mixed disorders when you start with a metabolic acidosis. That's incredibly useful. The source mentions some other prediction methods too.
Yes, it does. It notes a couple of other rules of thumb. One is that PaCO2 should decrease by about 1.25 millimole Hg for every 1 millimole decrease in HCO3 below 25. Another simpler approximation mentioned is PaCO2 and HCO3 plus 15. These generally provide a similar range of expected values to check against the measured PaCO2.
And just to confirm, for metabolic disorders, the compensatory change in PaCO2 always moves in the same direction as the primary change in HCO3 relative to normal values.
That's correct. In metabolic acidosis, HCO3 is low, and the compensatory PaCO2 is also low. In metabolic alkalosis, HCO3 is high, and the compensatory PaCO2 will also be high. Think low, low, high, high.
Got it. Makes sense. Okay, moving on to metabolic alkalosis. Primary problem here is a high HCO3.
Right, so the pH is tending towards alkaline. The body compensates by hypoventilating, breathing more shallowly or slowly. This is an attempt to retain CO2, raise the PaCO2, and shift that Henderson-Hasselbalch ratio back towards a more normal pH. The expected increase in PaCO2 is approximately 0.75 millimole Hg for every 1 millimole increase in HCO3 above 24. Yeah. Or another rule mentioned is about a 6 millimole Hg rise in PaCO2 for every 10 millimole rise in HCO3. And that simpler rule, PaCO2 at HCO3 plus 15, is also listed here as an approximation.
Okay, so high HCO3, compensatory high PaCO2. Makes sense. Now let's flip to the respiratory side. Respiratory alkalosis, primary problem. Low PaCO2, usually from hyperventilation.
Exactly. Low PaCO2 drives the pH up. Here, the compensation involves a decrease in HCO3. This happens relatively quickly through chemical buffering, mostly intracellular buffer shifting things around. But the main, more sustained compensation comes from the kidneys. The kidneys decrease their bicarbonate reabsorption and excretion. And the magnitude of this HCO3 drop differs depending on how long the hypocapnia, the low PaCO2, has been present. acute versus chronic.
Right. The source distinguishes between acute and chronic compensation here. How does that work?
In acute respiratory alkalosis, think minutes to hours, the HCO3 drops only modestly. The rule given is about 0.2 millimole decrease in HCO3 for every 1 millimole Hg decrease in PaCO2 below 40. This is mainly due to that immediate buffering effect. But in chronic respiratory alkalosis, which means it's been going on for more than several hours, usually days, the renal compensation becomes much more effective. Here, the HCO3 decreases more substantially by about 0.4 millimole for every 1 millimole Hg decrease in PaCO2 below 40.
Okay, 0.2 for acute, 0.4 for chronic drop in bicarb per point drop in PaCO2. And in these primary respiratory disorders with compensation, the PaCO2 and the compensating HCO3 end up moving in the same direction. Absolutely. Both low in alkalosis, both high in acidosis, but the change from baseline is sort of opposite conceptually.
Yes, that's a good way to think about it. Primary respiratory acidosis. PaCO2 goes high, so the compensatory response makes HCO3 go high. Both high. Primary respiratory alkalosis. PaCO2 goes low. Compensatory response makes HCO3 go low. Both low. When you look at their absolute values compared to the normal range, 40 for PaCO2, 24 for HCO3, they appear to move together. But it's crucial to remember it's a primary change in one, PaCO2, driving a compensatory change in the other, HCO3. This is fundamentally different from a mixed disorder where you have two independent forces pushing those values.
Right, that's a really key distinction. Okay, finally, respiratory acidosis. Primary problem is a high PaCO2, usually due to hypoventilation.
Correct. High PaCO2 drives the pH down, making it acidic. The body compensates by increasing HCO3, trying to buffer that excess acid. And again, the timing matters, acute versus chronic. In acute respiratory acidosis, minutes to hours, the HCO3 increases only slightly, by about 0.1 millimole for every 1 millimole Hg increase in PaCO2 above 40. This is primarily from buffering. But in chronic respiratory acidosis, lasting more than, say, 24 hours, the renal compensation kicks in significantly. The kidneys generate and retain more bicarbonate, increasing HCO3 by about 0.4 millimole for every 1 millimole Hg increase in PaCO2 above 40. The source also notes that compensatory HCO3 rarely goes above about 38 millimole from pure respiratory compensation alone.
Okay, so 0.1 for acute, 0.4 for chronic rise in bicarb per point rise in PaCO2. High PaCO2, compensatory high HCO3. We have these predictable responses nailed down now, but the source notes something that initially sounded a bit confusing. It says that changes in PaCO2 and HCO3 in opposite directions inherently indicate a mixed acid-base disturbance. Given the compensation rules we just discussed, where values can end up both high or both low, can you clarify what that phrasing means?
Yeah, that wording can be a bit tricky if taken out of context. What the source means there is changes in directions relative to the expected compensatory response. Let's use our examples again. If you have a primary metabolic acidosis, the problem is low HCO3. The expected compensation is a low PaCO2. Now, if you measure a patient and find they have low HCO3, but their PaCO2 is high, that high PaCO2 is clearly not compensatory for the metabolic acidosis. It's moving in the opposite direction from where compensation should take it. It signals an independent problem, a coexisting respiratory acidosis. Similarly, if you have primary respiratory acidosis, the problem is high PaCO2. The expected compensation is a high HCO3. If you instead find a high PaCO2 combined with a low HCO3, that low HCO3 is not compensating. It's moving opposite to the expected direction and indicates a coexisting metabolic acidosis.
Ah, okay. That makes much more sense. So it's not about the absolute direction of the values compared to the normal range, like 7.40, 40, 24. It's about whether the compensating variable is doing what it should be doing according to those rules and equations for a simple disorder. If it's going the wrong way or doing way too much or way too little compared to the prediction, that's the sign of an independent mixed disorder.
Exactly. You got it. The compensatory rules essentially set the standard. Deviations from those rules are what signal complexity. The source also brings up the acid-base nomogram, figure 55.1, as a visual tool that can help with this.
Right, the nomogram. How does that work?
It's a graph that plots pH against PaCO2, and it has lines or bands representing the typical bicarbonate levels. Crucially, it shows shaded regions or confidence bands where the values typically fall for each of the simple disorders with their expected range of compensation. These are usually based on 90% or 95% confidence limits from population studies. So if a patient's set of values, pH, PaCO2, and calculated HCO3, plots within the shaded area for, say, metabolic acidosis, it suggests that the compensation might be appropriate for a simple disorder.
Might be appropriate, but the source adds a really significant caution about relying solely on the nomogram, doesn't it?
Yes, a very critical caution. It explicitly states that just because a patient's values plot neatly within one of the simple disorder compensation ranges on the nomogram, it does not rule out a mixed disturbance. It's entirely possible for two or more primary disorders to coexist in such a way that their combined effect on pH, PaCO2, and HCO3 results in a point that just happens to fall within a simple disorder's typical range on that chart. This is precisely why using the quantitative relationships, those prediction equations like Winter's, and the delta analysis we'll discuss later, is considered more precise and absolutely necessary for a truly thorough diagnosis.
Okay, so the nomogram is a helpful visual starting point maybe, but the real diagnostic heavy lifting is in the calculations and following a systematic approach. Let's move on to that complexity then. Section 3. Unmasking complexity mixed acid-base disorders. You mentioned these are common and can be quite dangerous.
They are indeed common, particularly in settings like the ICU, or with patients who have multiple underlying medical problems. And yes, they can be dangerous, because the combined effect of multiple disorders can push the pH to life-threatening extremes, either very low or very high. And just to reiterate, these aren't just compensation. They represent two or more independently coexisting primary disorders happening at the same time.
And this is where the anion gap becomes such a vital diagnostic tool, isn't it? Especially for spotting these hidden metabolic issues.
Absolutely crucial. The anion gap, or AG, is central to diagnosing mixed disorders, particularly when metabolic acidosis or alkalosis might be involved. As a reminder, it's calculated from the standard electrolytes, serum Na plus serum clara plus serum HCO3O. It represents the difference between the major measured cations, sodium, and the major measured anions, chloride and bicarbonate. That gap essentially consists of unmeasured anions, like albumin, phosphate, sulfate, and organic anions, minus unmeasured cations, like potassium, calcium, magnesium.
Right. And the source specifically hammers home the need to correct the calculated AG for the patient's albumin level.
Yes, this is absolutely critical for accurate interpretation and something easily overlooked. Albumin is the most abundant protein in plasma and carries a significant negative charge, making it the biggest contributor to the unmeasured anions in the gap calculation. If a patient's serum albumin level is low, which is very common in sick patients, their calculated anion gap will be spuriously low. It won't accurately reflect the presence of other unmeasured anions like lactate or ketones. To get a more accurate picture, the source states you must adjust the AG. The rule given is to add 2.5 millimole to the calculated AG for every 1 GDL that the patient's serum albumin concentration is below the normal average, which is typically considered 4.5 GDL.
Okay, let's run that calculation. Say a patient has an albumin of 2.0 GDL, which is quite low, and their calculated AG from the electrolytes is 10 millimole.
Right, so their albumin is 2.5 GDL below the normal 4.5. 4.5, 2.0 equals 2.5. You multiply that difference by the correction factor, 2.5 GDL, 2.5 millimole per GDL per 6.25 millimole. You add this correction amount to their uncorrected AG, 10 plus 6.25 equals 16.25 millimole. So their corrected anion gap is actually 16.25. This is the value you should compare against the normal AG range, typically 6-12 millimole with an average around 10. In this case, 16.25 is clearly elevated.
That correction makes a huge difference. What does a high corrected AG specifically tell us?
A high corrected AG is a major red flag. It signals the accumulation of excessive amounts of unmeasured anions in the plasma. In the context of metabolic acidosis, this is the critical clue that the acidosis is due to the presence of specific organic acids like lactic acid, keto acids, or certain inorganic acids like in renal failure, or toxins whose anions are not routinely measured as part of the standard electrolyte panel, Cl and HCO3.
Perfect. Let's use the examples of mixed disorders from Table 55-2 in the source to see how combining the AG information with the compensation rules helps us piece things together. First up, metabolic acidosis combined with respiratory alkalosis.
Okay, so typically you'll identify a high AG metabolic acidosis. First, let's say it's lactic acidosis from sepsis. You calculate the corrected AG, it's high. Then you use Winter's equation, or another rule, to predict the expected PaCO2 compensation for that degree of metabolic acidosis. But when you look at the patient's actual measured PaCO2 on the blood gas, you find it's even lower than what Winter's equation predicted. This tells you the patient is hyperventilating more than required just to compensate for the metabolic acidosis. There must be an independent process driving that extra ventilation, a primary respiratory alkalosis, perhaps also driven by the sepsis or pain or anxiety.
Okay, so the signature is high corrected AG plus a measured PaCO2 that is lower than predicted by Winters. Got it. How about the opposite mix? Metabolic acidosis plus respiratory acidosis.
Again, you'll likely start by identifying a high AG metabolic acidosis, for example, from diabetic ketoacidosis or renal failure. You calculate the corrected AG, it's high. You calculate the expected PaCO2 using Winter's equation, but this time the patient's measured PaCO2 is higher than predicted. They aren't compensating adequately. In fact, they seem to be retaining CO2. This indicates an independent problem causing hypoventilation and a primary respiratory acidosis, maybe due to underlying COPD or respiratory muscle fatigue or sedation.
Makes sense. High corrected AG plus a measured PaCO2 higher than predicted by Winters. Now let's look at alkalotic mixes. Metabolic alkalosis combined with respiratory alkalosis.
Right, so here you have a primary metabolic alkalosis, meaning an elevated HCO3. Both disorders are pushing the pH upwards, making the patient quite alkalemic. You look at the expected respiratory compensation for metabolic alkalosis. Remember, the PaCO2 should rise to compensate. You use the rules like PaCO2 increasing by 0.75 millimole Hg per 1 millimole rise in HCO3. But you find the patient's measured PaCO2 hasn't risen as much as predicted. It might even be low or normal. This tells you there's a primary respiratory alkalosis, hyperventilation, happening concurrently, preventing the expected compensatory rise in PaCO2. The pH might be significantly elevated as a result. An example might be a patient with liver disease, causing respiratory alkalosis, who is also on diuretics, causing metabolic alkalosis.
Okay, that makes sense. Now, the really tricky one, metabolic alkalosis plus respiratory acidosis. The source says the pH might even look normal here.
Exactly. This one could definitely mask itself if you only look at the pH. You have a metabolic alkalosis driving the HCO3 high, tending to raise pH, and you have a respiratory acidosis driving the PaCO2 high, tending to lower pH. How do you spot it? You apply the compensation rules from both directions. First, look at the metabolic alkalosis component, high HCO3. Predict the compensatory rise in PaCO2. Is the measured PaCO2 even higher than predicted? If yes, that suggests a primary respiratory acidosis is present. Second, look at the respiratory acidosis component, high PaCO2. Predict the compensatory rise in HCO3. Is the measured HCO3 even higher than predicted for chronic respiratory acidosis compensation? If yes, that suggests a primary metabolic alkalosis is present. So you see deviations from expected compensation in both directions, because the two disorders are pushing the pH in opposite directions. Metabolic alkalosis raises it, respiratory acidosis lowers it. The net effect on the measured pH can be minimal, perhaps even landing it in the normal range. But the simultaneous presence of a higher than expected PaCO2 for that level of HCO3 and the higher than expected HCO3 for that level of PaCO2 is the dead giveaway for the mixed disorder. A classic example is a patient with COPD, chronic respiratory acidosis, who is also taking diuretics, metabolic alkalosis.
Wow. That is a fantastic illustration of why you absolutely must look beyond just the pH value and apply those compensation rules systematically. What about mixed metabolic disorders? The source mentions metabolic acidosis plus metabolic alkalosis coexisting. How do we detect that?
This combination is often suspected and usually only reliably detectable when one of the components is a high Ag metabolic acidosis. So you'll calculate the corrected Ag and it will be high. That tells you there's definitely a high Ag acidosis present. But the key diagnostic step here, really emphasized in the source, is comparing the change in the anion gap. We call this the delta Ag or DAY to the change of the bicarbonate level. Delta HCO3 or HCO3.
The delta-delta comparison, how exactly do we calculate that?
You need baseline normal values. Let's use 10 millimole for a normal Ag and 25 millimole for a normal HCO3 as the source suggests. First, calculate the gauge. This is the patient's corrected Ag minus the normal Ag, so corrected Aq10. This represents the excess unmeasured anions. Second, calculate the HCO3. This is a normal HCO3 minus the patient's measured HCO3, so 25 patients HCO3. This represents the bicarbonate deficit, or how much bicarbonate has been lost or consumed. Now, in a pure, uncomplicated high Ag metabolic acidosis, the bicarbonate is consumed buffering the accumulated acid. So the amount of bicarbonate lost, HCO3, should roughly equal the amount of excess unmeasured anion gained. You'd expect HCO3.
Okay, that makes sense. A one-to-one relationship in pure high Ag acidosis. So what does it mean if the J is significantly greater than the HCO3 go?
That's the signal. That's the clue. If DAGE is much bigger than HCO3, it means there's more of an anion gap than can be accounted for by the decrease in bicarbonate alone. Where did the extra bicarbonate buffering come from? It implies that there must be a coexisting metabolic alkalosis that is also raising the bicarbonate level, partially masking the full extent of the bicarbonate drop caused by the high Ag acidosis. So some of that gap-producing acid has effectively been buffered by bicarbonate that was added independently by a concurrent metabolic alkalosis process like vomiting or diuretic use. This HCO3 finding is a powerful way to spot this complex mix, even if the measured bicarbonate or pH doesn't look dramatically low.
Fantastic. It much greater than AHCO3 points strongly to high AG acidosis plus metabolic alkalosis. What about the scenario of metabolic acidosis plus another metabolic acidosis? How does that fit?
Right. This scenario refers to the coexistence of two different types of metabolic acidosis occurring simultaneously. A high AG acidosis, like lactic acidosis, and a normal AG, hyperchloremic acidosis, like from severe diarrhea. The source mentions that in this specific case, the total decrease in bicarbonate, the HCO3, is accounted for by the combined effect of the increase in the anion gap and the increase in chloride, often looked at as the change in chloride, from its normal baseline. So part of the bicarbonate drop is explained by the rise in AG, and the rest is explained by the rise in chloride. An example given is a patient with diarrhea, which causes normal AG hyperchloremic acidosis due to bicarbonate loss, who then develops sepsis and lactic acidosis, high AG acidosis.
This really underscores the need for that systematic approach we talked about. You absolutely cannot just eyeball these numbers and hope to catch everything.
Absolutely not. You'll miss things. And the source provides a very clear step-by-step process for exactly that systematic evaluation.
Perfect. Let's walk through that diagnostic journey now. Section 4, detailing the steps from Table 5533 for acid-based diagnosis. How should you approach this?
Step 1. Obtain arterial blood gas, ABG, and a full electrolyte panel, including sodium, potassium, chloride, bicarbonate total CO2, BUN, creatinine, glucose, and ideally albumin, simultaneously. This is crucial. Drawing them at the same time gives you a consistent snapshot of the patient's status, and if possible, get these before starting any major therapy, like large volume fluid resuscitation or bicarbonate infusion, which could alter the values and muddy the picture.
Okay, get all the puzzle pieces at once before disturbing the scene. Step 2.
Step 2. Compare the bicarbonate values. Look at the HCO3 value reported on the ABG analysis and compare it with the bicarbonate value reported on the serum electrolyte panel, which is often listed as total CO2 or CO2 content. These two values measure slightly different things, but should generally agree within about 2 millimole. If they differ significantly more than that, it raises a red flag. Maybe the samples weren't drawn simultaneously, or there was lab processing error. You need to re-verify the data before proceeding because reliable numbers are absolutely foundational for the next steps.
Check your data integrity. Good point. Step 3.
Step 3. Evaluate the anion gap, AG. Calculate it using the formula we discussed, neutrality plus, throughout the HCO3 using the values from the electrolyte panel. Compare this raw AG to the lab's normal range, which is typically somewhere around 6 to 12 millimole, with an average often cited around 10 millimole.
And because albumin matters so much. Step 4.
Step 4. Absolutely critical. Correct the calculated AG for the patient's serum albumin level, especially if the albumin is low. Remember the rule. Add 2.5 millimole to the uncorrected AG for every 1 GDL of albumin below the reference normal, usually 4.5 GDL. This gives you the physiologically relevant AG adjusted for the albumin deficit. This corrected AG is what you use for interpretation.
Okay, we have our corrected true AG calculated. Step 5.
Step 5. Interpret the corrected AG. If it's high, significantly above the normal range, AG 12-14 millimole, immediately start thinking about the major categories of high AG metabolic acidosis. The source lists the 4 big ones to consider. Ketoacidosis, diabetic alcoholic starvation, lactic acid acidosis, type A or B, renal failure, uremic acidosis, and toxins like salicylates, methanol, ethylene glycol. This helps focus your diagnostic investigation right away.
Okay, high AG points to those 4 main causes. What if the corrected AG is normal? Step 6.
Step 6. If the corrected AG is normal, but the patient is clearly acidotic, low pH and or low bicarbonate, then you're dealing with a non-AG metabolic acidosis, also known as hyperchloremic metabolic acidosis. The source guides you to consider the 2 primary categories here. Bicarbonate loss, usually from the GI tract, like severe diarrhea or certain fistulas, or renal tubular acidosis, RTA, where the kidneys aren't handling acid or bicarbonate properly. In these cases, the decrease in bicarbonate is matched by an increase in chloride concentration, which is why the AG stays normal.
So the AG acts like a fork in the road. High AG points one way, normal AG in the face of acidosis points another. Step 7.
Step 7. Estimate the expected compensatory response for the primary disorder you suspect. Use the quantitative relationships or equations we discussed earlier, detailed in Table 55-1. For example, if you suspect metabolic acidosis, use Winter's equation to predict the PACO2. If you suspect chronic respiratory acidosis, predict the expected rise in HCO3. Compare the patient's actual measured value, PACO2 or HCO3, to the predicted value for a simple, uncomplicated disorder of that magnitude. This is the crucial step where you check if the body's response is just right or if it's too much or too little, signaling a mixed problem.
This is where we actively look for those deviations from the expected compensation.
Oh, yeah.
Step 8.
Step 8. Compare the delta Ag and the delta HCO3, HCO3. This is that powerful step we discussed specifically for detecting a mixed high Ag metabolic acidosis coexisting with a metabolic alkalosis. Calculate Te, patients corrected Ag10, and HCO3, 25 patients HCO3. If Ag is significantly greater than HCO3, your suspicion for a coexisting metabolic alkalosis should be very high. If Ag is roughly equal to HCO3 within a few points, it's likely a pure high Ag acidosis. If Ag is significantly less than HCO3, it might suggest a mixed high Ag and non-Ag acidosis occurring together, or sometimes it can be a clue about laboratory error.
That delta-delta check seems really key for unmasking those complex metabolic mixes. The source also briefly mentions a step 9, comparing the change in chloride with the change in sodium. How does that fit in?
Yes. Step 9 involves looking at the change in chloride concentration relative to the change in sodium concentration. This step is mentioned in the text, though perhaps less emphasized than the Ag and compensation rules. It can provide some additional clues, particularly in assessing non-Ag acidosis. In a pure non-Ag acidosis caused by alkali loss, like diarrhea, the increase in chloride concentration should roughly parallel the decrease in bicarbonate, HCO3, while the sodium concentration remains relatively stable. Looking at the magnitude of change in chloride relative to sodium, sometimes formalized as the chloride-sodium difference, or change ratio, can occasionally help differentiate between causes or spot more complex electrolyte shifts, although using the urine anion GAF UAG is usually a more direct way to differentiate renal versus GI causes of non-Ag acidosis.
Okay. This systematic approach, starting with simultaneous, accurate labs, checking the bicarbonate agreement, calculating and correcting the Ag, using the Ag to guide you towards major causes, predicting the expected compensation using formulas, and then critically comparing the A and HCO3 really provides a robust framework. It feels like a logical pathway to navigate any acid-based problem, whether it looks simple on the surface or is hiding complexity.
It truly is. It functions like a diagnostic algorithm, guiding you methodically through the possibilities. It ensures you consider all the angles and don't miss a hidden secondary or tertiary disorder that a quick glance at just the pH or bicarbonate might completely overlook. It's how you achieve that mastery we're aiming for.
Excellent. Now that we have this solid framework, let's dive even deeper into the specific conditions mentioned in the source material. Section 5, a deep dive into specific metabolic disorders. We'll start with metabolic acidosis, remembering we split it into high Ag and non-Ag types.
That's the primary split, yes. And remember, a metabolic acidosis with a normal corrected anion gap invariably means it's hyperchloremic. The chloride level will be elevated to fill the gap left by the low bicarbonate. That's your non-Ag acidosis.
Let's talk about treatment principles first, specifically regarding alkali therapy, like giving sodium bicarbonate. The source seems quite cautious about its routine use.
It is, and for good reason. The general recommendation from the source is that alkali therapy, giving bicarbonate, should be reserved for severe acidemia, typically defined as a pH falling below about 7.0 or 7.1. This is because bicarbonate administration carries risks, like volume overload, hydronatremia, worsening intracellular acidosis in some cases, potential for overshoot alkalosis, and hasn't consistently shown clear benefit in improving outcomes in many common acidosis scenarios, like moderate lactic acidosis or DKA. However, the source makes a critical distinction. Alkali therapy is generally indicated when the underlying acidosis is caused by acids whose anions cannot be metabolized back into bicarbonate by the body. In other words, when there's no potential HCO3 readily available from the accumulated anions.
Okay, explain that concept of potential HCO3 a bit more.
Potential HCO3 refers to those accumulated acid anions that the body can metabolize and convert back into bicarbonate once the underlying problem causing their accumulation is fixed. Think of beta-hydroxybutyrate and acetoacetate in ketoacidosis, or lactate in lactic acidosis. When you treat the DKA with insulin, or restore perfusion in lactic acidosis, the body takes those accumulated anions and effectively turns them back into bicarbonate, helping to correct the acidosis endogenously. The amount the corrected Ag is elevated above normal gives you a rough estimate of the concentration of these potentially metabolizable anions. In contrast, anions that accumulate in advanced renal failure, like phosphates and sulfates, or anions from certain toxins, like formate from methanol or glycolate from ethylene glycol, are non-metabolizable. The body can't easily convert them back to bicarbonate.
Ah, I see. So if the acidosis is due to these metabolizable anions, like in DKA or most lactic acidosis, the primary treatment is fixing the underlying problem. giving insulin, restoring perfusion. The body will then generate its own bicarbonate from those anions. Giving exogenous bicarbonate in these cases might not be necessary unless the acidemia is truly life-threatening, and it carries the risk of causing a dangerous overshoot alkalosis later when the body does convert those anions back.
Precisely. That's the core rationale. Therefore, the source identifies the specific patient groups who generally should receive alkali therapy. First, patients with non-AG hyperchloremic metabolic acidosis, because here bicarbonate has been definitively lost from gut or kidney and won't be regenerated from other anions. Second, patients with high AG acidosis caused by the accumulation of non-metabolizable anions, such as the uremic acidosis seen in advanced chronic kidney disease or certain toxic ingestions. The goal in these situations isn't usually to normalize the pH or bicarbonate immediately or completely, but rather to slowly and cautiously increase the plasma HCO3 towards a safer target, often around 20-22 milliliters, while carefully monitoring the patient and avoiding overcorrection.
And how is this alkali typically administered if it's needed?
Depending on the severity and clinical context, it can be given orally using sodium bicarbonate tablets or a liquid preparation like Scholl's solution, which contains sodium citrate. Citrate is metabolized to bicarbonate. Or, in more acute or severe situations, it's given intravenously as a sodium bicarbonate infusion, often diluted in dextrose solution.
Okay, let's delve into those four main causes of high anion gap acidosis listed in Table 55-4. Lactic acidosis, ketoacidosis, toxins, and renal failure, CKD. Clinically, when you identify a high AG acidosis, how do you approach the patient to narrow down the cause?
Well, beyond getting the ABG, electrolytes, calculating the corrected AG, and applying the compensation rules, the source emphasizes the importance of the initial screening steps. This absolutely includes taking a focused history, asking specifically about potential toxin exposures, medications, alcohols, antifreeze, known history of diabetes or chronic alcohol use, symptoms suggesting kidney failure, uremia, clinical signs of poor tissue perfusion, shock, heart failure, sepsis, or conditions known to alter cellular metabolism, like cancer, severe infection, certain drugs. Then targeted lab tests are key. Checking blood ketones, ideally beta-hydroxybutyrate, BUN and creatinine for kidney function, a lactate level, and sometimes examining the urine for specific clues like oxalate crystals, which strongly suggest ethylene glycol poisoning. This initial workup helps direct further investigation.
Let's start with lactic acidosis in more detail. What are the different types and key considerations here?
Lactic acidosis is defined by elevated plasma L-lactate levels, usually 4 to 5 millimole L, causing acidosis. The source categorizes the causes primarily into type A and type B. Type A lactic acidosis is a more common form and results from inadequate tissue oxygenation or perfusion. Think of conditions like circulatory shock, cardiogenic, septic, hypovolemic, severe heart failure, profound anemia, localized tissue ischemia like mesenteric ischemia, a bowel infarction, carbon monoxide poisoning, or specific mitochondrial defects that impair oxygen utilization. Type B lactic acidosis occurs when systemic tissue oxidation seems adequate, but there's a problem with cellular metabolism leading to lactate overproduction or impaired lactate clearance. This includes a diverse group of causes like certain malignancies, especially hematologic, HIV infection and some related medications, uncontrolled diabetes, severe liver or kidney failure of impairing lactate clearance, thiamine deficiency, critical cofactor in glucose metabolism, severe infection sepsis, even without overt shock, and various drugs and toxins like metformin, ethanol, propylene glycol, and the toxic alcohols.
The source specifically highlighted bowel ischemia as a critical example.
Yes, it emphasized recognizing acute mesenteric ischemia, particularly in elderly patients or those with known vascular disease or on vasopressor medications, as a critical clinical scenario that can lead to rapid development of severe lactic acidosis. It's often a surgical emergency.
And there's a variant called D-lactic acidosis.
That's a much less common form, primarily seen in patients who have had jejunal bypass surgery for obesity or those with short bowel syndrome. It's caused by abnormal gut bacteria producing the D isomer of lactate, which isn't effectively metabolized by human enzymes, and, importantly, often isn't detected by the standard clinical lactate assays which measure L-lactate. Patients can have neurological symptoms like confusion and ataxia, along with an unexplained high AG acidosis.
What about the treatment for the more common L-lactic acidosis?
The absolute priority always is to identify and aggressively correct the underlying cause. If it's type A due to poor perfusion, restoring blood flow and oxygen delivery is paramount. Fluids, pressors, treating heart failure, etc. Regarding alkali therapy, bicarbonate, as we discussed, its role is controversial, especially in moderate lactic acidosis, pH 7.1.
There's little evidence it improves outcomes and potential harms exist. It's generally considered only for severe, life-threatening acidemia, usually pH 7.0, with the goal of potentially improving cardiovascular responsiveness to catecholamines. But even then, it must be given cautiously, aiming only to raise the pH to a slightly safer level, the example on 7.2, or the bicarbonate to maybe 10, 12 millimole, definitely not aiming for full normalization. The risks include fluid overload, hypernatremia, hypercapnia if ventilation isn't increased, and paradoxically worsening intracellular acidosis. Furthermore, if the underlying cause is successfully treated, the accumulator lactate will be rapidly converted back to bicarbonate by the liver and kidneys. Giving too much exogenous bicarbonate beforehand can lead to a significant and dangerous rebound metabolic alkalosis during recovery.
That's a really important point about the rebound alkalosis, a fine line to walk with treatment. Okay, let's move to the next major category, ketoacidosis. Diabetic ketoacidosis, DKA first.
Right, DKA results from the severe lack of effective insulin action, typically in type 1 diabetes, but can occur in type 2 under stress. This leads to uncontrolled glucose production by the liver, hyperglycemia, and massive breakdown of fats into keto acids, primarily beta-hydroxybutyrate and acetoacetate, which accumulate in the blood, causing a high AG metabolic acidosis. Common triggers are infections, missed insulin doses, or other acute illnesses. The hallmarks are hyperglycemia, ketonemia, ketones in the blood, and the high AG acidosis.
And the source mentioned a specific variant, euglycemic DKA.
Yes, that's an important one to be aware of. Euglycemic DKA is characterized by significant ketoacidosis, high AG, positive ketones, but with blood glucose levels that are normal or only slightly elevated, 450 milli-GDL. This can occur in patients with some residual insulin production during pregnancy with prolonged starvation, or notably in patients taking SGLT2 inhibitor medications, a class of diabetes drugs. It's important because the absence of marked hyperglycemia might lead clinicians to miss the diagnosis of DKA if they aren't specifically checking for ketones or the AG in the right clinical context.
And the standard urine or blood test for ketones isn't always perfect for detecting DKA.
Correct. The standard nitroprusside test, used in urine dipsticks and some older serum ketone assays, primarily detects acetoacetate. However, in DKA, especially early on or when tissue perfusion is poor, the predominant keto acid is often beta-hydroxybutyrate. The ratio shifts. So the nitroprusside test can sometimes underestimate the severity of ketosis. Measuring plasma beta-hydroxybutyrate directly is considered more accurate for diagnosing and monitoring DKA treatment. Also, it's worth noting that DKA often presents as a mixed acid-base disorder. The severe hyperglycemia causes an osmotic diuresis, leading to significant volume depletion and loss of electrolytes, including sodium and potassium. As the kidneys try to excrete the keto acid anions, they're often lost with cations like sodium or potassium, leading to retention of chloride to maintain electrical neutrality. This can result in a hyperchloremic, non-AG component developing alongside the high AG acidosis, which might manifest as the AHCO3 being greater than the age.
What about alkali therapy in DKA? Is bicarbonate used?
Generally, no. Routine bicarbonate therapy is not recommended in DKA. It hasn't shown benefit and carries potential risks, including paradoxical CNS acidosis, hypokalemia, and potentially delayed clearance of ketones. It's reserved only for cases of extreme life-threatening acidemia, for example, pH 6.9 or 7.00, or if there's accompanying circulatory shock that's unresponsive to fluids and pressors. Even then, it's given cautiously and in limited amounts. The cornerstone of DKA treatment isn't bicarbonate. It's aggressive fluid resuscitation with isotonic saline to restore volume and tissue perfusion, careful correction of potassium deficits, which are almost always present despite potentially normal serum levels initially, and continuous intravenous infusion of regular insulin to shut off ketone production and allow glucose utilization. Treatment continues until the hyperglycemia resolves, the acidosis clears, and crucially, the anti-gap normalizes.
Okay, fluids, insulin, potassium, that's DKA. What about alcoholic ketoacidosis, aka how does that differ?
AKA typically occurs in individuals with chronic alcoholism, usually following a period of heavy drinking accompanied by poor nutritional intake and often vomiting. Like DKA, it involves the accumulation of keto acids, again, predominantly beta-hydroxybutyrate, causing a high AG metabolic acidosis. The key distinguishing feature from DKA is usually the absence of significant hyperglycemia. Blood glucose is often normal or even low in AKA. The mechanism involves alcohol suppressing glucose production, combined with starvation-depleting glycogen stores, leading to increased fat breakdown and ketogenesis, exacerbated by high glucagon and cortisol levels. Mixed acid-base disorders are extremely common in AKA. Patients may simultaneously have lactic acidosis from poor perfusion or thiamine deficiency, respiratory alkalosis from liver disease or alcohol withdrawal, and/or metabolic alkalosis from vomiting. Because vomiting is so common, finding that GHCO3 signature is quite frequent, indicating the mixed high Ag acidosis and metabolic alkalosis.
And does the issue with the nitroprusside ketone test also apply in AKA?
Yes, very much so. Beta-hydroxybutyrate is usually the predominant ketone, so the nitroprusside test can be misleadingly negative or only weakly positive initially. As the patient is treated, usually with fluids containing dextrose and thiamine, circulation improves, the redox state shifts, and beta-hydroxybutyrate gets converted to acetoacetate. This can paradoxically cause the nitroprusside test to become more positive during the recovery phase, which can be confusing if you're not aware of the shift.
Is kidney function typically different between AKA and DKO patients?
Often, yes. Patients with AKA frequently have relatively preserved underlying renal function compared to many DKA patients, though acute kidney injury can certainly occur in AKA too. This preserved renal function allows them to excrete larger amounts of ketoacid anions in the urine, along with AG allocations like sodium, potassium, or ammonium. This urinary loss of potential bicarbonate, coupled with chloride retention, can also contribute to a mixed high Ag and non-Ag hyperchloremic picture in AKA, where the HCO3 might exceed the Ag.
How is AKA treated?
Treatment primarily involves intravenous fluids, typically saline containing dextrose, D5NS or D512NS. The dextrose is crucial to suppress further ketogenesis by stimulating insulin release and providing substrate. Thiamine supplementation is absolutely essential, given prophylactically, because alcoholics are often deficient, and giving glucose without thiamine can precipitate Wernicke's encephalopathy. Meticulous monitoring and correction of electrolyte abnormalities is critical. Hypokalemia, hypophosphatemia, and hypomagnesemia are very common and can become severe during treatment, especially after glucose administration drives them into cells. Severe hypophosphatemia in particular can cause major complications like muscle weakness, hemolysis, rhabdomyolysis, and respiratory arrest. Bicarbonate therapy is rarely needed. Addressing associated conditions like GI bleeding, pancreatitis, or pneumonia is also key.
And starvation ketoacidosis is also mentioned briefly.
Yes, the source lists prolonged starvation as another potential cause of ketoacidosis and a high Ag picture, although it's typically less severe than DKA or AKA. The mechanism is similar. Depleted glycogen stores lead to fat breakdown and ketone production for energy.
Okay, that covers ketoacidosis. Let's move to the third big category of high Ag acidosis, toxins. Salicylates like aspirin first.
Salicylate intoxication is a classic cause and can be complex. In adults, it often presents with a primary respiratory alkalosis initially because salicylates directly stimulate the respiratory center in the brainstem, causing hyperventilation and low PuCO2. However, as the intoxication progresses, or with larger ingestions, a high Ag metabolic acidosis develops. Salicylates themselves uncouple oxidative phosphorylation and disrupt metabolism, leading to the accumulation of organic acids, including lactate, ketoacids, and the salicylate anion itself contributes to the gap. So the typical picture in significant adult salicylate poisoning is often a mixed disorder, respiratory alkalosis plus high Ag metabolic acidosis. The pH can be variable, sometimes even near normal initially, despite severe underlying disturbances.
How is salicylate poisoning treated? It sounds like getting rid of the drug is key.
Yes, treatment focuses heavily on enhancing elimination. Initial management includes gastric decontamination if appropriate, gastric lavage with isotonic saline, not bicarbonate, and activated charcoal. The mainstay of treatment is intravenous sodium bicarbonate infusion. The goal here is twofold. First, to correct the systemic metabolic acidosis, and second, and critically, to alkalinize the urine, aiming for a urine pH 7.5. Making the urine alkaline significantly increases the ionization of salicylic acid in the renal tubules, trapping it there and dramatically enhancing its excretion by the kidneys. Careful monitoring is needed, especially if a significant respiratory alkalosis is also present, to avoid causing excessive systemic alkalemia, high blood pH. Potassium levels must be watched closely and repleted, as alkali therapy and diuresis can worsen hypokalemia. Glucose-containing fluids are often used. For severe intoxication, high levels, altered mental status, renal failure, pulmonary edema, hemodialysis is highly effective at removing salicylates and correcting the acid-based disturbances.
Okay, urine alkalinization is key for salicylates. Now, the toxic alcohols and the concept of the osmolar gap.
Right. The osmolar gap is another crucial diagnostic tool when suspecting ingestion of certain toxins, particularly the alcohols. It's the difference between the osmolality measured directly in the lab using an osmometer and the osmolality calculated from the concentrations of the major osmotically active solutes in the blood. The calculated osmolality is typically estimated using a formula like 2 plus glucose 18 plus BUN 2.8 using standard US units. Some formulas also include ethanol if measured. Normally, the measured and calculated osmolality should be close, with the difference the osmolar gap of less than 10-15 millisiePa. A significantly elevated osmolar gap, 15-20, strongly suggests the presence of unmeasured osmotically active substances in the blood. The source lists examples like mannitol, radiographic contrast agents, but most importantly in this context, ethanol, isopropyl alcohol, ethylene glycol, methanol, and propylene glycol. The osmolar gap, combined with the clinical history and the anion gap findings, is invaluable in diagnosing toxic alcohol ingestions.
And which of these toxic alcohols typically cause both a high anion gap and a high osmolar gap?
The two main culprits that cause both a significant high Ag metabolic acidosis and an elevated osmolar gap are ethylene glycol and methanol. Isopropyl alcohol typically causes an elevated osmolar gap. Both the parent alcohol and its metabolite acetone are osmotically active, but usually does not cause a significant high Ag acidosis unless a severe overdose leads to secondary complications like shock and lactic acidosis.
Let's talk about ethylene glycol, e.g. then, found in antifreeze.
Yes, ethylene glycol is commonly found in antifreeze and coolants. When ingested, it's metabolized by the enzyme alcohol dehydrogenase, ADH, in the liver to highly toxic acidic metabolites, primarily glycolic acid and oxalic acid. These metabolites are responsible for the profound high Ag metabolic acidosis and the severe end organ damage, particularly acute kidney injury due to calcium oxalate crystal deposition in the tubules, as well as CNS depression, cardiopulmonary effects, and hypocalcemia. Clinically, you suspect Eg poisoning with a high Ag acidosis plus an elevated osmolar gap. Importantly, the osmolar gap may be present before the anion gap becomes significantly elevated, as the parent Eg molecule contributes to the osmolar gap, while the Ag develops as Eg is metabolized into acidic products. Finding oxalate crystals in the urine is a classic, though not always present, clue.
How is ethylene glycol poisoning treated? Blocking that metabolism seems key.
Absolutely. Treatment involves blocking the metabolism of Eg by ADH. The preferred agent now is fompazole, which is a direct inhibitor of ADH. It's given intravenously as a loading dose, followed by maintenance doses. An older alternative, though less commonly used now due to side effects and difficulty in dosing, is intravenous ethanol, which competes with Eg for the ADH enzyme. Supportive care is crucial, including managing the acidosis, bicarbonate may be needed for severe cases, correcting electrolytes, and potentially giving cofactors like thiamine and pyridoxine, which might help steer metabolism away from toxic pathways. Hemodialysis is often required and is highly effective at removing both apparent Eg and its toxic metabolites, as well as correcting the acidosis and electrolyte abnormalities. Indications for dialysis typically include severe acidosis, pH 7.25-7.300, a significantly elevated Ag or osmolar gap, evidence of end organ damage, especially kidney injury, or very high Eg levels. Fondazole or ethanol therapy is continued until the Eg level is undetectable and the acidosis molar gap have resolved.
Okay, fompazole and dialysis for Eg. What about methanol? Found in windshield washer fluid, some solvent.
Correct. Methanol, wood alcohol, is found in windshield washer fluid, some fuels, solvents, and improperly distilled spirits. Like Eg, it's metabolized by ADH, first to formaldehyde, and then rapidly to formic acid. Formic acid is the primary toxic metabolite responsible for the characteristic end organ damage, particularly severe optic nerve injury, leading to blurred vision, visual field defects, and potentially permanent blindness, and damage to the basal ganglia in the brain. It also causes a profound high Ag metabolic acidosis. Lactic acid and keto acids may also contribute to the acidosis. Similar to Eg, methanol itself is osmotically active, so ingestion typically causes an elevated osmolar gap, which may precede the development of the full anion gap acidosis as metabolism occurs. Treatment principles are very similar to Eg poisoning. Supportive care, blocking ADH metabolism with fompazole preferred or ethanol, and often hemodialysis to remove methanol and formic acid and correct the acidosis. Prompt treatment is essential to prevent irreversible visual loss.
Okay, very similar approach for methanol. What about propylene glycol? You mentioned it's used in IV medications.
Yes. Propylene glycol is used as a solvent or vehicle in many intravenous medications, including lorazepam, diazepam, phenytoin, nitroglycerin, and others. Toxicity usually occurs in the ICU setting when patients receive large or continuous infusions of these medications, leading to accumulation of propylene glycol. It can cause an elevated osmolar gap and, as it's metabolized, also partly by ADH, to lactic acid and other organic acids, it can cause a high Ag metabolic acidosis. So the source advises considering propylene glycol toxicity in any ICU patient with an unexplained high AG acidosis, hyperosmolality, and clinical deterioration, especially if they were receiving medications known to contain it, like continuous lorazepam infusions for sedation or alcohol withdrawal. Treatment involves stopping the offending infusion. Flumpazole might be considered if significant acidosis is present, and hemodialysis can remove propylene glycol if needed.
Good one to keep in mind in the ICU. Isopropyl alcohol, rubbing alcohol.
Yes, isopropyl alcohol is common in rubbing alcohol and disinfectants. Ingestion is relatively common. It's metabolized by ADH to acetone. The key difference from EG and methanol is that the parent isopropyl alcohol itself causes much of the toxicity, CNS depression, gastritis, and its metabolite acetone, while causing ketosis and contributing to the osmolar gap, is relatively less toxic and doesn't typically cause a significant high AG acidosis. Acetone is rapidly excreted by the lungs and kidneys. So the classic picture of isopropyl alcohol ingestion is CNS depression, hemorrhagic gastritis, ketosis, positive ketones, often strongly positive, and a high osmolar gap due to both isopropyl alcohol and acetone, but usually a normal or near normal anion gap unless complications like shock occur. Hypoglycemia can also be common. Treatment is primarily supportive care, fluids, monitoring, pressors if needed, respiratory support. Hemodialysis might be considered for very severe cases with prolonged coma, hemodynamic instability, or extremely high levels for HG 400 milladl.
Okay, high osmolar gap, but usually normal AG for isopropyl. One more toxin mentioned. Pyroglutamic acid acidosis from acetaminophen.
Yes, this is a less common but important cause of high AG metabolic acidosis associated with acetaminophen paracetamol use. It's formally called 5-oxyprolinuria. It typically occurs not just with massive overdoses, but sometimes in malnourished or critically ill patients, especially with sepsis or liver kidney disease, who are taking therapeutic or modestly increased doses of acetaminophen over time. The proposed mechanism involves depletion of glutathione, leading to dysregulation of the gamma-glutamyl cycle and accumulation of pyroglutamic acid, 5-oxyproline. The clinical clue is an unexplained high AG metabolic acidosis in a patient taking acetaminophen, particularly if the osmolar gap is normal. Pyroglutamic acid doesn't contribute much to osmolality. Treatment involves stopping the acetaminophen. Barb sodium bicarbonate might be needed for severe acidosis. N-acetylcysteine, NAC, the antidote for acute acetaminophen overdose liver toxicity, has been used, but its role in treating pyroglutamic acidosis itself is not well established according to the source.
Fascinating. Okay, the last major category of high AG acidosis. Chronic kidney disease, CKD.
Right. As kidney function declines in CKD, the ability to excrete the daily load of metabolic acids diminishes. Initially, in moderate CKD, like stage 3 and early stage 4, this often manifests as a non-AG hyperchloremic metabolic acidosis, as the kidneys can still excrete some acid but have trouble regenerating bicarbonate effectively, leading to chloride retention. However, as CKD progresses to more advanced stages, late stage 4 and stage 5, often called uremic acidosis, the kidneys also lose the ability to adequately filter and excrete various unmeasured anions, such as phosphates, sulfates, urate, and other organic acid anions. The accumulation of these unmeasured anions, combined with the severely impaired acid excretion, especially reduced ammonia production, lead to the development of a high AG metabolic acidosis. The body tries to buffer this retained acid, partly by using buffers in bone, calcium carbonate, which contributes to the bone disease seen in CKD, but helps stabilize the serum bicarbonate level to some extent, though significant acid retention still occurs.
And how is the metabolic acidosis of CKD treated? You mentioned alkali therapy is indicated here.
Yes. Unlike the recommendations for DKA or lactic acidosis, oral alkali replacement therapy is generally recommended for the metabolic acidosis associated with CKD, both for the high AG uremic acidosis of stage 5 and for the non-AG acidosis often seen in stages 3 and 4. The goal is typically to maintain the serum bicarbonate concentration consistently above 22 millimole. The rationale is strong. Untreated chronic metabolic acidosis in CKD is associated with increased muscle catabolism, worsening bone disease, osteodystrophy, impaired protein metabolism, inflammation, and potentially faster progression of the kidney disease itself. Treatment usually involves modest daily doses of oral alkali, such as sodium bicarbonate tablets or an oral sodium citrate solution, like Scholl's solution citrate is metabolized to bicarbonate. The dose is titrated to achieve the target serum bicarbonate level, often requiring around 1.0-1.5 millimole day of alkali. Dietary changes, like increasing fruit and vegetable intake, which provide alkali precursors like citrate, may also help.
Okay, that wraps up the high AG causes. Let's switch gears to non-anion gap metabolic acidosis, table 55-5. These are the hyperchloremic acidoses. What are the main mechanisms?
Right, normal corrected AG, but the patient is acidotic, low HCO3, low pH. The two main mechanisms are either direct loss of bicarbonate-rich fluid or the inability of the kidneys to excrete the daily metabolic acid load properly, but without accumulation of unmeasured anions. In both cases, as bicarbonate falls, the kidneys tend to reabsorb more chloride to maintain electrical neutrality, leading to hyperchloremia. That's why the change in chloride KLEL tends to roughly equal the fall in bicarbonate CO3 in these conditions.
Let's start with GI bicarbonate loss. Diarrhea seems like the classic example.
It is the most common cause of non-AG acidosis worldwide. Intestinal fluid, especially from the lower GI tract, is rich in bicarbonate. Severe or prolonged diarrhea leads to significant bicarbonate loss, resulting in systemic metabolic acidosis. An important point the source makes is about interpreting the urine pH. Even though the patient is systemically acidotic, the kidneys should be responding appropriately by ramping up acid excretion, mainly in the form of ammonium, NH4+. Because NH4+ buffers protons in the urine pH might actually be relatively high, Fear G6, which could be misleading. The key is whether the kidneys are successfully excreting acid, not just the urine pH itself.
So how do we use the urine test to differentiate bicarbonate loss from diarrhea versus a kidney problem like renal tubular acidosis, RTA? They both cause non-AG acidosis.
This is where the urine anion gap, UAG, becomes very helpful, as mentioned in the source. The UAG is calculated from urine electrolytes. UAG equals next D plus K plus U, U. The UAG provides an indirect estimate of urine ammonium NH4 plus excretion, because NH4 plus is the major unmeasured cation in urine that balances urinary chloride. If the kidneys are responding appropriately to systemic acidosis, as they should in diarrhea, they will significantly increase NH4 plus excretion to get rid of acid. This high NH4 plus requires a high concentration of urinary chloride, CLU, to accompany it for charge balance. This results in net plus U plus K plus U being less than CLU, yielding a negative UAG, COG negative 20 MEQL. A negative UAG strongly suggests an extrarenal cause of the non-AG acidosis, like diarrhea. Conversely, if the kidneys are the source of the problem and are failing to excrete adequate NH4+, as occurs in most types of RTA, then urinary CLU will be relatively low compared to net plus U plus K plus U, resulting in a positive UAG plus 30 MEQL. A positive UAG in the setting of non-AG acidosis points towards a renal tubular origin, RTA. The source does note limitations of UAG, example, presence of other anions like ketones, and mentions that direct measurement of urine ammonium, if available, is preferred, but UAG is often used clinically.
That UAG concept is really useful. Negative UAG suggests diarrhea. Positive UAG suggests RTA. What are other GI causes of bicarbonate loss?
Besides diarrhea, the source lists things like drainage from pancreatic or small bowel fistulas or tubes, ureterosigmoidostomy, where urine flows through the colon, allowing chloride reabsorption and bicarbonate secretion, and use of certain drugs like calcium chloride, magnesium sulfate, or clostiramine, which can bind bicarbonate in the gut. Treatment for GI bicarbonate loss generally involves fluid resuscitation and replacing the lost bicarbonate, either intravenously or orally, depending on the severity and volume status.
Okay, now let's talk about the other major category of non-AG acidosis, renal tubular acidosis, RTA. The problem originates in the kidney tubules themselves.
Exactly. RTA refers to a group of disorders where metabolic acidosis results from specific defects in renal tubular function related to either bicarbonate reabsorption or hydrogen ion secretion, occurring despite relatively preserved glomerular filtration rate, GFR, at least initially.
Let's break down the types. Proximal RTA, also known as type 2 RTA.
Type 2 RTA is caused by a defect in the proximal tubule's ability to reabsorb the filtered bicarbonate load. Normally, about 85% of filtered bicarbonate is reabsorbed here. When this process is impaired, large amounts of bicarbonate are delivered distally, overwhelming the distal nephron's capacity and leading to bicarbonate wasting in the urine. It's often associated with other proximal tubular defects, a condition called Fanconi syndrome, which can involve glycosuria, glucose in urine despite normal blood sugar, aminoaciduria, phosphaturia, and urticaria. Key features of proximal RTA include hypokalemia, due to distal K plus wasting, driven by high distal Ni plus HCO3 deliverer, and non-AG acidosis. A distinguishing characteristic is the urine pH. When the plasma bicarbonate level is low, below the patient's reduced reabsorptive threshold, often around 15-18 millimol, the distal nephron can still acidify the urine appropriately, so the urine pH will be acidic, 5.5. However, If you try to treat the acidosis by giving bicarbonate and raise the plasma level above their threshold, the excess bicarbonate spills into the urine, making the urine pH inappropriately alkaline.
Another hallmark is a high fractional excretion of bicarbonate, FeHCO3 10-15%, when the serum bicarbonate is raised above the defective threshold, for example, 20 millimole. Treating proximal RTA can be challenging because giving bicarbonate often requires large doses due to the spillover and can significantly worsen the hypokalemia by further enhancing distal potassium secretion. Causes can be inherited or acquired, including drug-induced forms, for example, from acetazolamide to pyramid ifosfamide. Treatment often involves using potassium citrate preparations rather than just sodium bicarbonate.
Okay, proximal RTA equals bicarb wasting, hypokalemia, variable urine pH depending on plasma bicarb. What about distal RTA, the classic type 1?
Distal RTA, type 1, results from an inability of the distal tubule, specifically the alpha intercalated cells in the collecting duct, to secrete hydrogen ions effectively. This impairs the kidney's ability to excrete the daily metabolic acid load and to maximally acidify the urine. Typical features include hypokalemia, due to associated distal K plus wasting mechanisms, non-AG metabolic acidosis, and importantly, an inappropriately high urine pH, consistently 5.5, often 6.0, despite the presence of systemic acidemia. Because acid secretion is impaired, urinary ammonium excretion is low, resulting in a positive urine anion gap, UAG. Other common findings include hypocitraturia, low urine citrate, which normally inhibits calcium stone formation, and hypercalciuria, high urine calcium. This combination predisposes patients to developing kidney stones, nephrolithiasis, and calcium deposits in the kidney tissue, nephrocalcinosis, which are classic complications of type 1 RTA. Bone disease, rickets osteomalacia, is also common due to chronic acidosis buffering by bone.
Causes can be inherited, genetic mutations affecting H+80 ATPase pumps or other transporters, or acquired, example, autoimmune diseases like Sjogren's syndrome, certain drugs like amphotericin B, lithium, ifosfamide. Treatment involves first correcting the hypokalemia, then providing alkali therapy, usually as potassium citrate or sodium citrate bicarbonate. The goal is to maintain the serum bicarbonate in the normal range, for example, 24-26 millibel level. Patients with type 1 RTA generally respond readily to relatively modest doses of alkali compared to type 2. Correcting the acidosis has significant benefits, including preventing further stone formation, improving bone density and growth in children, and potentially preserving kidney function.
Okay, distal type 1 equals impaired H plus secretion, hypokalemia, always high urine pH, 5.5, positive UAG, risk of stones and bone disease. That leaves type 4 RTA, described as generalized distal nephron dysfunction.
Type 4 RTA is characterized by impaired function of the entire distal nephron segment, affecting both potassium and hydrogen ion secretion. The hallmark feature is hyperkalemia, high serum potassium, that seems disproportionate to the degree of any underlying kidney function decline, GFR. Like type 1 RTA, there's depressed urinary ammonium excretion, leading to a non-AG metabolic acidosis and often a positive UAG. But unlike type 1, the urine pH can often still be acidified below 5.5, although maybe not maximally. The primary issue seems to be related to either aldosterone deficiency or aldosterone resistance in the distal tubule. This type of RTA is commonly seen in patients with underlying kidney compromise, particularly diabetic nephropathy, chronic interstitial nephritis, or urinary tract obstruction. A specific subset mentioned is hypereninemic hypaldosteronism, often seen in older adults, frequently with diabetes and mild to moderate CKD, GFR typically 20 to 50 milliliter. These patients present with persistent hyperkalemia, often 5.2 to 6.0 minor EQL, non-AG acidosis, often hypertension and sometimes heart failure, with the hyperkalemia and acidosis seeming out of proportion to their GFR.
They have low plasma renin and aldosterone levels. Many common medications can cause or exacerbate type 4 RTA or hyperkalemia, including ACE inhibitors, ARBs, NSAIDs, potassium-sparing diuretics, spironolactone, eplerenone, amiloride, triamterene, trimethoprim, and heparin. The source provides a list in Table 55.5. Treatment for type 4 RTA has dual goals: correcting both the acidosis, similar principles to type 1 RTA using sodium bicarbonate or citrate, and the hyperkalemia. Importantly, achieving normokalemia often improves renal acid excretion. Strategies for hyperkalemia include dietary potassium restriction, discontinuing offending medications, using loop diuretics if volume overloaded, using potassium-binding resins like sodium polystyrene sulfonate, SPS, though often poorly tolerated, or the newer, more palatable agent Patromer. For patients with confirmed isolated hypaldosteronism, low-dose fludrocortisone, a synthetic mineralocorticoid, can be cautiously used but requires careful monitoring for fluid retention and hypertension.
Okay, type 4 is distal dysfunction. Hyperkalemia is key, often aldosterone related, often in CKD diabetes. Are there any other causes of non-AG acidosis mentioned?
Yes, the source briefly lists a few others: administration of acid loads like ammonium chloride, rarely used now, or cationic amino acids in hyperalimentation fluids, loss of potential bicarbonate through urinary excretion of ketoacid anions, especially during treatment of DKA when GFR is good, leading to chloride retention. Expansion acidosis, which can occur with rapid infusion of large volumes of normal saline, 0.9% ACL, effectively diluting the plasma bicarbonate concentration. Accumulation of hippurate from toluene sniffing. Toluene itself causes a high Ag acidosis, but its metabolite hippurate is rapidly excreted with kininocations, leading to a non-Ag component too. Use of certain cation exchange resins like cholestyramine.
That provides a really comprehensive overview of metabolic acidosis, both high Ag and non-Ag. Let's finally move to the other side of the pH scale, metabolic alkalosis, section 6.
All right, metabolic alkalosis. Here we have an elevated blood pH, alkalemia, caused by a primary increase in serum bicarbonate concentration, HCO3. The expected compensatory response, as we discussed, is hypoventilation, leading to an increase in PaCO2. Clinically, metabolic alkalosis is often associated with hypochloremia, low serum chloride, and hypokalemia, low serum potassium, which are frequently involved in its pathogenesis or maintenance.
How does metabolic alkalosis actually develop and persist? The source talks about generation and maintenance phases.
That's a key concept. For metabolic alkalosis to develop and persist, two things usually need to happen. First, there's a generation phase, where there's either a net gain of bicarbonate or bicarbonate precursors like citrate or acetate into the extracellular fluid, or are, more commonly, a net loss of non-volatile acid from the body, primarily hydrochloric acid, HCl, lost from the stomach via vomiting or nasogastric suction. Losing H+ effectively leaves behind an excess HCO3. Second, there's a maintenance phase. Normally, the kidneys have a huge capacity to excrete excess bicarbonate. So for metabolic alkalosis to persist, kidney function must be altered in a way that prevents this excretion of the excess HCO3. The force identifies two main groups of factors that maintain metabolic alkalosis by impairing renal bicarbonate excretion. 1. Factors associated with ECF volume contraction and/or chloride depletion and/or potassium depletion, often leading to secondary hyperreninemic hyperaldosteronism. These conditions enhance tubular bicarbonate reabsorption. This is often called saline responsive or chloride responsive metabolic alkalosis, because correcting the volume of chloride potassium deficit allows the kidneys to excrete the excess bicarbonate. A key finding here is usually a low urine chloride concentration, 10-20 MEQL, indicating avid renal salt retention. 2. Factors associated with primary mineralocorticoid excess, like primary aldosteronism or Cushing's syndrome, or severe potassium depletion itself. Here, volume status might be normal or expanded, and hypertension is often present. The high aldosterone levels directly stimulate distal hydrogen and potassium secretion, maintaining the alkalosis. This is often called saline-resistant or chloride-resistant metabolic alkalosis because giving saline won't correct it and might worsen hypertension volume overload. Urine chloride is typically normal or high, 20 to 40 BQL in these cases, unless there's also superimposed volume depletion.
That distinction between saline-responsive low urine seal and saline-resistant high urine seal seems really important for diagnosis and treatment. How does the diagnostic approach in Table 55-6 use these factors?
The diagnostic approach heavily relies on assessing the patient's extracellular fluid volume, ECFV status, contracted, normal, or expanded, blood pressure, low, normal, or high, serum potassium level, and crucially, the urine chloride concentration. For example, if a patient has metabolic alkalosis with ECFV contraction, hypotension, and hypokalemia, along with a low urine chloride, 10-20, it strongly suggests a saline-responsive cause like vomiting, prior diuretic use, or post-hypercapnic alkalosis. If a patient has metabolic alkalosis with ECFV expansion, hypertension, and hypokalemia, along with a high urine chloride, 40, it points towards a saline-resistant cause involving mineralocorticoid excess, primary aldosteronism, Cushing's, renal artery stenosis. You then check plasma renin and aldosterone levels to differentiate further. If a patient is normotensive but hypokalemic with alkalosis, the urine chloride helps again. Low urine chloride suggests ongoing GI losses, surreptitious vomiting, laxative abuse, or remote diuretic use. High urine chloride suggests current diuretic use, Bartter or Gittleman syndrome, inherited salt-losing tubulopathies, severe potassium depletion, or magnesium deficiency.
Gittleman syndrome is specifically associated with hypocalciuria, low urine calcium, which helps distinguish it from Barter's. Urine electrolyte patterns, including sodium and potassium, also provide clues about ongoing losses versus maintenance phase.
Okay, that systematic approach using volume status, BP, K+A, and especially urine chloride seems key. Let's run through some specific causes listed in Table 55-6. Exogenous bicarbonate loads.
This involves giving too much bicarbonate or precursors. Examples include excessive IV or oral sodium bicarbonate, large volume blood transfusions, citrate anticoagulant is metabolized to bicarbonate, citrate used during apheresis, overuse of certain antacids combined with cation exchange resins, or sometimes high alkali content in enteral feeding formulas. The source notes this rarely causes sustained alkalosis if kidney function and volume status are normal, as healthy kidneys can excrete the excess load. The risk is much higher in patients with CKD or ECF volume depletion.
Makes sense. What about the large category of saline responsive causes? ECFE contraction, K plus depletion, and secondary hyperreninemic hyperaldosteronism. Starting with GI origin, vomiting, gastric aspiration.
This is a very common cause. Loss of gastric fluid, which is rich in hydrochloric acid, HCl, leads to a net addition of bicarbonate, HCO3, to the ECF generation phase. Initially, during active vomiting, the increased filtered load of bicarbonate might exceed the reduced proximal reabsorptive capacity, leading to bicarbonaturia, alkaline urine, and obligate potassium loss with the bicarbonate categorises. However, once vomiting stops or becomes chronic, the resulting ECF volume depletion, chloride depletion, and potassium depletion all act to enhance renal bicarbonate reabsorption maintenance phase. Aldosterone levels also rise due to volume depletion, further promoting H+ and K+ secretion. Urine chloride becomes very low, as the kidneys avidly conserve salt. Treatment requires correcting the underlying deficits by administering fluids containing both sodium chloride, NaCl, and potassium chloride, KCl. This restores volume, repletes chloride, along with bicarbonate excretion, and corrects hypokalemia, enabling the kidneys to finally excrete the excess bicarbonate.
Okay, vomiting and G-suction is classic saline responsive. What about renal origin causes in this category? Diuretics.
Loop diuretics, like furosemide and thiazide diuretics, are major causes of metabolic alkalosis. They work by inhibiting salt reabsorption in the nephron. This leads to ECF volume contraction, sometimes called contraction alkalosis. Chronically, they also increase salt delivery to the distal nephron, which stimulates potassium and hydrogen ion secretion, contributing to hypokalemia and alkalosis. The alkalosis is maintained by the ongoing ECF volume contraction, secondary hyperaldosteronism, triggered by volume depletion, potassium deficiency, and the direct effect of the diuretic impairing salt reabsorption. Urine chloride will be high while the diuretic is active, but low once the effect wears off if volume depletion persists. Treatment involves discontinuing the diuretic if possible and administering isotonic saline and potassium to correct the deficits.
What are some other renal causes mentioned?
The source lists inherited salt-losing tubulopathies, like Bartter syndrome and Gittleman syndrome, which mimic the effects of loop and thiazide diuretics respectively, causing saline-responsive hypokalemic metabolic alkalosis. Administration of large doses of non-reabsorbable anions, like certain penicillins, carbenzilin, ticagrelin, can increase the electrical potential in the distal tubule, enhancing H+ and K+ secretion. Magnesium deficiency is highlighted because it often coexists with and potentiates hypokalemic metabolic alkalosis, possibly by enhancing distal acidification via renin-aldosterone stimulation. It's common in chronic alcoholism. Severe potassium depletion itself can both initiate metabolic alkalosis by increasing renal net acid excretion and maintain it by stimulating distal H+ secretion via H+ TK plus ATPase upregulation. This type of alkalosis is often resistant to saline alone and requires aggressive potassium repletion. Rebound or post-treatment alkalosis can occur after successful treatment of lactic acidosis or ketoacidosis, as the accumulated organic anions are metabolized back to bicarbonate.
If exogenous bicarbonate was also given during treatment, a significant overshoot alkalosis can result. Post-hypercapnic alkalosis occurs when PICO2 is rapidly normalized, for example by mechanical ventilation, in a patient with chronic respiratory acidosis. The high bicarbonate level generated by the kidneys as compensation persists temporarily, leading to metabolic alkalosis until the kidneys can excrete the excess bicarbonate, which requires adequate chloride and volume.
That covers the saline responsive group well. Now, the saline resistant category, ECFE expansion, hypertension, and mineralocorticoid excess.
Right. In these conditions, there's excessive activity of mineralocorticoids, like aldosterone, or mineralocorticoid-like effects, leading to increased sodium reabsorption, volume expansion, hypertension, increased potassium secretion, hypokalemia, and increased hydrogen ion secretion, metabolic alkalosis. The key is that the mineralocorticoid effect is primary, not secondary to volume depletion. This increased aldosterone activity persistently stimulates the epithelial sodium channel, ENaC, in the distal nephron, leading to salt retention and hypertension. It also stimulates renal outer medullary potassium channel, ROMK, and H+ ATPase activity, causing persistent categorises, potassium loss in urine, and net acid excretion. Persistent potassium depletion can also cause nephrogenic diabetes insipidus, leading to polydipsia and polyuria. Causes can be divided based on renin levels. High renin causes include conditions like renal artery stenosis, renin-secreting tumors, or malignant hypertension, where high renin drives secondary hyperaldosteronism. Estrogen therapy can also increase renin substrate. Low renin causes point to primary adrenal overproduction of mineralocorticoids or exogenous sources. This includes primary aldosteronism, Conn syndrome, due to adrenal adenoma or hyperplasia. Certain congenital adrenal enzyme defects, like 11-hydroxylase or 17-hydroxylase deficiency, Cushing's syndrome disease, excess cortisol having mineralocorticoid effects, ingestion of licorice, glyceric acid inhibits cortisol breakdown, or use of drugs like fludrocortisone.
And Little syndrome is mentioned here too.
Yes, Little syndrome is a rare inherited condition caused by gain-of-function mutations in the genes encoding the eNAC channel itself. This leads to excessive sodium reabsorption in the distal nephron, independent of aldosterone. Clinically, it mimics primary aldosteronism, presenting with early-onset hypertension, volume expansion, hypokalemia, and metabolic alkalosis, but plasma renin and aldosterone levels are suppressed due to the volume expansion. Treatment specifically targets the overactive eNAC channel using potassium-sparing diuretics that block eNAS, such as amiloride or triamterene. These agents effectively correct the hypertension and hypokalemia.
What are the typical symptoms of metabolic alkalosis itself?
Symptoms are often nonspecific and can overlap with those of associated electrolyte disturbances like hypokalemia or hypocalcemia, since alkalosis decreases ionized calcium. Neurological symptoms can range from mental confusion, lethargy, or obtundation to delirium or seizures in severe cases. Neuromuscular excitability can manifest as paresthesias, tingling, numbness, especially around the mouth and in extremities, muscle cramping, or even tetany. Cardiovascular effects can include arrhythmias, especially if hypokalemia is present. Alkalosis can also worsen tissue oxygen delivery, Bohr effect shift, and potentially cause hypoxemia in patients with underlying COPD by reducing ventilatory drive. Associated electrolyte abnormalities like hypokalemia and hypophosphatemia can cause their own symptoms, weakness, cardiac effects.
How is metabolic alkalosis treated?
The approach depends on the underlying cause and the volume electrolyte status. The first goal is always to identify and correct the underlying stimulus for the alkalosis if possible. For example, stop vomiting with antiemetics. Use PPIs for gastric acid hypersecretion. Discontinue diuretics if appropriate. Treat underlying Cushing's or aldosteronism surgically or medically. The second goal is to eliminate the factors maintaining the alkalosis, primarily ECF volume contraction and potassium chloride deficiency for the saline responsive types. Potassium deficits always need to be repaired, usually with potassium chloride. For saline responsive alkalosis with ECF volume contraction, administering isotonic saline, 0.9% ACL, is key. This restores volume, provides chloride, which allows the kidney to excrete bicarbonate paired with sodium, and helps correct the alkalosis. If saline administration is contraindicated due to volume overload or heart failure, the source mentions using acetazolamide, a carbonic anhydrase inhibitor, at doses like 125 to 250 milligrams IV. Acetazolamide promotes renal excretion of bicarbonate along with sodium and potassium. However, it requires adequate kidney function and necessitates careful monitoring and supplementation of potassium losses. For extremely severe, life-threatening metabolic alkalosis, for example, pH 7.65 to 7.70 with severe symptoms, the source mentions that intravenous administration of hydrochloric acid, HCl, usually 0.1N solution, or ammonium chloride can be considered, but it strongly advises against this approach due to significant risks. HCl infusion requires a central line, carries a risk of hemolysis, needs careful pharmacy preparation, and has a high potential for errors and harm. Dialysis might be a safer option in refractory severe cases. For specific conditions like Little syndrome, the treatment is targeted NEC blockade with amiloride or triamterene. For mineralocorticoid excess, specific antagonists like spironolactone or epinone are used.
Okay, that's a very thorough look at metabolic alkalosis. Let's wrap up with the primary respiratory disorders. Section 7. Deep dive into specific respiratory disorders, starting with respiratory acidosis.
Respiratory acidosis is defined by a primary increase in PaCO2, hypercapnia, due to inadequate alveolar ventilation, leading to a decrease in blood pH, acidemia. Common causes involve severe pulmonary disease, like advanced COPD, severe asthma exacerbation, ARDS, respiratory muscle fatigue, for example, in neuromuscular diseases, or prolonged severe respiratory distress, or problems with central ventilatory control, like opioid overdose, brainstem injury, obesity, hypoventilation syndrome.
And the compensation involves bicarbonate, acute versus chronic again.
Yes, the body compensates by increasing serum bicarbonate HCO3 to buffer the excess carbonic acid. In acute respiratory acidosis, developing over minutes to hours, the compensation is mainly via cellular buffering, and the HCO3 rises only slightly, approximately 1 mmol, for every 10 mmol He increase in PaCO2 above 40. In chronic respiratory acidosis, persisting for days, renal compensation becomes much more significant. The kidneys increase bicarbonate reabsorption and generation, leading to a more substantial rise in HCO3, approximately 4 millimole, range 3 to 5, for every 10 mmol Hg increase in PaCO2 above 40. As mentioned before, the compensatory HCO3 rarely exceeds about 38-40 millimole, even in chronic states.
What are the clinical features? Do they differ between acute and chronic?
Yes, the symptoms depend heavily on the severity and rapidity of onset. Acute hypercapnia, especially if it develops rapidly, primarily affects the central nervous system due to CO2 crossing the blood-brain barrier and lowering CSF pH. Symptoms can include anxiety, dyspnea, shortness of breath, confusion, disorientation, psychosis, hallucinations, and eventually somnolence and coma, CO2 narcosis. Cerebral vasodilation can cause headaches and signs of increased intracranial pressure like papilledema. Chronic hypercapnia, developing slowly, allows for adaptation, so symptoms might be more subtle initially. They often include sleep disturbances, daytime somnolence, morning headaches, memory impairment, personality changes, poor coordination, and motor disturbances like tremor, muscle jerks, myoclonus, or asterixis, a flapping tremor. These neurological signs can sometimes mimic primary neurological disorders or raised intracranial pressure.
What are the major categories of causes listed in Table 55-7?
The source groups them nicely. 1. Central nervous system issues impairing respiratory drive. This includes drugs, anesthetics, sedatives like benzodiazepines, opioids like morphine, brainstem injury or stroke, infections, encephalitis, tumors, or primary sleep disorder breathing syndromes like central sleep apnea or obesity hypoventilation syndrome, OHS. 2. Airway obstruction. Acute upper airway obstruction, foreign body, laryngospasm, angioedema, or severe lower airway obstruction like status asthmaticus, severe anaphylaxis, or inhalation injury. 3. Parenchymal lung disease. Conditions severely impairing gas exchange or increasing the work of breathing, such as end-stage COPD, emphysema, chronic bronchitis, severe pneumonia, acute respiratory distress syndrome, ARDS, pulmonary edema, extensive pneumoconiosis, or severe restrictive lung diseases affecting the lung tissue itself. Restrictive disorders affecting the chest wall or pleura, like kyphoscoliosis or massive pleural effusions, can also lead to hypoventilation due to high work of breathing and eventual muscle fatigue. 4. Neuromuscular disorders. Conditions causing respiratory muscle weakness or paralysis, including poliomyelitis, Guillain-Barré syndrome, myasthenia gravis, muscular dystrophies, spinal cord injury affecting respiratory muscles, or drugs causing paralysis. 5. Miscellaneous, including severe obesity, contributing to OHS and restrictive physiology, issues with mechanical ventilation, improper settings, large dead space ventilation, ventilator malfunction, conditions causing markedly increased CO2 production like sepsis or burns, overwhelming ventilation capacity, or situations where high PEEP settings on a ventilator reduce cardiac output and increase dead space ventilation. The source also mentions permissive hypercapnia, used sometimes in managing ARs, where high PaCO2 is tolerated to minimize ventilator-induced lung injury. In such cases, bicarbonate infusion might be considered to keep pH above a critical threshold, for example 7.2.
How is respiratory acidosis diagnosed and treated?
Diagnosis is primarily made by the ABG showing elevated PaCO2 and low pH, or near normal pH if fully compensated chronically. Identifying the underlying cause requires a thorough history, especially regarding drugs, underlying lung or neuromuscular disease, sleep symptoms, physical examination, chest imaging, pulmonary function tests, PFTs, and sometimes specific workup for non-pulmonary causes, toxicology screens, neurological evaluation, sleep studies. Treatment depends entirely on the severity, acuity, and underlying cause. Acute severe respiratory acidosis is a life-threatening emergency requiring immediate intervention to reverse the cause, for example, naloxone for opioid overdose, bronchodilators for asthma, and restore adequate ventilation, often necessitating endotracheal intubation and mechanical ventilation. Oxygen therapy should be administered cautiously in patients with chronic CO2 retention, like COPD, as excessive oxygen can sometimes worsen hypercapnia by reducing hypoxic drive and increasing VQ mismatch, though hypoxemia must still be treated.
Rapid correction of chronic hypercapnia should be avoided, as it could lead to post-hypercapnic metabolic alkalosis, potential cardiac arrhythmias, reduced cerebral perfusion, and seizures. Gradual lowering of PaCO2 toward the patient's baseline level is preferred. Ensuring adequate chloride and potassium intake can help the kidneys excrete the excess bicarbonate during recovery. Treating chronic respiratory acidosis is often difficult and focuses on optimizing management of the underlying lung disease or condition causing hypoventilation.
Ravel G, non-invasive ventilation for OHS, or stable COPD.
Okay, that covers respiratory acidosis. Finally, respiratory alkalosis.
Respiratory alkalosis is defined by primary alveolar hyperventilation, leading to a decreased PaCO2, hypocapnia, and an increased blood pH, alkalemia. The low PaCO2 shifts the carbonic acid equilibrium, consuming bicarbonate through cellular buffering mechanisms. Hypocapnia occurs whenever the stimulus to breathe exceeds the body's rate of CO2 production.
What are the relationships between the changes in PaCO2, pH, and bicarbonate here?
The source provides quantification for the acute phase. For every 1 millimole Hg decrease in PaCO2 below 40, the hydrogen ion concentration H+ falls by about 0.75 nmol, the pH increases by about 0.008 units, and the bicarbonate HCO3 falls by about 0.2 millimole due to buffering.
And the compensation involves further bicarbonate reduction by the kidneys.
Yes. If hypocapnia is sustained for more than a few hours, typically 2 to 6 hours, renal compensation begins. The kidneys reduce their net acid excretion, both ammonium and titratable acid, and decrease the reabsorption of filtered bicarbonate. Full renal adaptation takes days, requires normal volume status and kidney function. The kidneys appear to respond directly to the low PaCO2 levels. In chronic respiratory alkalosis lasting 3 to 5 days, the compensatory drop in HCO3 is more significant, falling by about 4 to 5 millimol for every 10 millimole Hg decrease in PaCO2 below 40. The corresponding fall in H+ is about 0.3 quarter-morel for every 1 millimole Hg PaCO2 decrease. Serum bicarbonate usually doesn't fall below 12 or 15 millimole from compensation alone. And remember, as we highlighted earlier, chronic respiratory alkalosis is the only simple acid-based disorder where renal compensation can potentially return the blood pH completely back into the normal range.
What are the clinical effects of respiratory alkalosis?
Effects vary depending on severity and chronicity. Acute, rapid drops in PaCO2 can significantly reduce cerebral blood flow due to vasoconstriction, leading to symptoms like lightheadedness, dizziness, confusion, paresthesias, especially circumoral and distal extremities, carpopedal spasm, and even syncope or seizures in severe cases. Cardiovascular effects in conscious individuals are usually minimal, but in anesthetized or mechanically ventilated patients, acute hypocapnia can decrease cardiac output and blood pressure. Arrhythmias can be precipitated, especially in patients with underlying heart disease. Alkalosis also shifts the oxygen-hemoglobin dissociation curve to the left, Bohr effect, impairing oxygen release to tissues, though this is usually clinically minor unless hypoxemia is severe. Alkalosis promotes intracellular shifts of electrolytes, potentially causing mild hypokalemia and hypophosphatemia. It also decreases the fraction of ionized calcium in the blood, though total calcium remains normal, contributing to the symptoms of neuromuscular excitability, paresthesias, tetany.
What's the prognostic significance?
Respiratory alkalosis is common in critically ill patients, and when severe, is often associated with a poor prognosis, likely reflecting the severity of the underlying illness driving the hyperventilation, like sepsis, severe pneumonia, shock. It can be an early warning sign of impending cardiopulmonary deterioration. Seeing normal capnia or rising PaCO2 in a patient who was previously hyperventilating due to hypoxemia is often an ominous sign of respiratory muscle fatigue and impending respiratory failure. It's also commonly encountered in patients on mechanical ventilation if settings provide excessive ventilation.
And there's a specific condition called hyperventilation syndrome.
Yes, this refers to a condition often related to anxiety or stress, where patients experience recurrent episodes of hyperventilation leading to symptomatic respiratory alkalosis. It can be quite disabling. Symptoms often include paresthesias, circumoral numbness, chest tightness or pain, mimicking cardiac pain, dizziness, lightheadedness, shortness of breath, or an inability to get a deep breath, palpitations, and occasionally frank tetany. The symptoms themselves can perpetuate anxiety and further hyperventilation, creating a vicious cycle. ABG testing during an episode typically shows acute or chronic respiratory alkalosis with hypocapnia, PaCO2, often 1530 millimole Hg, but significantly without accompanying hypoxemia, low blood oxygen. Diagnosis is one of exclusion. It's crucial to rule out serious underlying organic causes of hyperventilation, like pulmonary embolism, coronary artery disease, hyperthyroidism, or CNS disorders before attributing symptoms solely to anxiety.
What are the major causes of respiratory alkalosis listed in Table 55-7?
They fall into several categories. 1. Central nervous system stimulation. This includes pain, anxiety, psychosis, fever, cerebrovascular accident, stroke, CNS infections, meningitis, encephalitis, brain tumors, or trauma affecting the respiratory centers. 2. Hypoxemia or tissue hypoxia. Conditions causing low blood oxygen stimulate peripheral chemoreceptors, driving ventilation. Examples include high-altitude exposure, pneumonia, pulmonary edema, aspiration, interstitial lung disease, severe anemia, or low cardiac output states causing tissue hypoxia. 3. Drug or hormone effects. Pregnancy, progesterone is a respiratory stimulant, salicylate intoxication, direct medullary stimulation, methylxanthines like theophylline, catecholamines, cardiac failure, complex mechanism. 4. Stimulation of chest receptors, conditions irritating receptors in the lungs or chest wall, such as pulmonary embolism, pneumothorax, hemothorax, flail chest, or congestive heart failure. 5. Miscellaneous causes. Septicemia. Hyperventilation is often an early sign, especially in gram-negative sepsis. Hepatic failure, degree often correlates with severity of liver disease, mechanical hyperventilation, improper ventilator settings, heat exposure, or during the recovery phase from metabolic acidosis, when ventilatory drive may temporarily remain high. Importantly, strenuous exercise normally does not cause respiratory alkalosis because CO2 production increases proportionally to ventilation.
How is respiratory alkalosis diagnosed and treated?
Diagnosis is confirmed by ABG, showing low PaCO2 and elevated pH, unless fully compensated chronically. Serum potassium may be slightly reduced, and chloride often increased to compensate for the bicarbonate drop. Urine electrolytes can help differentiate acute, no increased HCO3 excretion, from chronic, reduced net acid excretion, lower HCO3. The main diagnostic challenge is identifying the underlying cause, which requires careful history, physical exam, and appropriate investigations based on the clinical suspicion, chest imaging, ECG, D-dimer, sepsis workup, etc. Hyperventilation syndrome remains a diagnosis of exclusion. Treatment is primarily directed at alleviating the underlying disorder causing the hyperventilation. If it's due to mechanical ventilation, settings, tidal volume, respiratory rate should be adjusted appropriately, perhaps by adding dead space to the circuit if necessary. For hyperventilation syndrome, reassurance and breathing techniques, like rebreathing into a paper bag temporarily to raise PaCO2, though used cautiously, can help abort acute episodes. Addressing the underlying psychological stress or anxiety disorder is key for long-term management. Sedatives or antidepressants should generally be avoided unless treating a specific psychiatric condition. Beta blockers might sometimes help manage associated hyperadrenergic symptoms.
Wow, okay. That was truly an exhaustive deep dive, mirroring the level of detail in the source material you provided. We started with that delicate tightrope act of normal pH balance, then explored how simple disorders, metabolic or respiratory acidosis and alkalosis, push the body off balance, detailed the body's predictable, quantifiable, compensatory counterpushes, walked step by step through that crucial systematic approach using the anion gap, albumin correction, compensation rules, and the delta comparison to diagnose not only simple disorders, but also those cunningly hidden mixed disturbances. And then finally, we dove deep into the specific causes, clinical features, diagnostic clues, and treatment strategies for each type of metabolic and respiratory acidosis and alkalosis, really aiming for that mastery you wanted.
It's quite something, isn't it? What's really fascinating when you lay it all out like this is seeing the interconnectedness of it all. How a problem primarily affecting the lungs immediately triggers a response in the kidneys, and vice versa. How a toxin ingested can disrupt cellular metabolism systemically, requiring interventions targeting both respiration and specific metabolic pathways. Or how seemingly simple things like fluid and electrolyte balance, volume status, chloride levels, potassium, play such a critical role in maintaining severe pH imbalances. Understanding these underlying principles and, crucially, applying that systematic diagnostic approach we outlined, that's really what allows you to confidently navigate these complex clinical presentations and figure out what's truly going on beneath the surface.
Exactly. It moves you beyond just memorizing definitions or normal ranges to actually understanding the why behind the numbers you see on that blood gas report, the pathophysiology driving the disturbance. You asked us to help you master this complex information like an elite professional would approach it, and by dissecting this comprehensive source material point by point, covering every concept mentioned, we've really aimed to give you that depth of understanding and a framework for applying it.
And it truly highlights the elegance. The elegance of the body's compensatory systems, even when they're under duress and signaling underlying pathology, they're trying their best to maintain that critical balance.
It's remarkable. And thinking about how many seemingly unrelated conditions, anything from a panic attack causing hyperventilation to chronic kidney disease preventing acid excretion to losing fluid from severe diarrhea or persistent vomiting, even certain medications or high altitude can all converge on disturbing this single critical pH balance. It just underscores how absolutely central this system is to overall health and physiological function.
It really does. And perhaps a final thought to leave you with, building on that. Consider the example of chronic kidney disease again. The source mentions how the body literally uses bone-dissolving calcium carbonate as a long-term buffer against chronic acidosis. It sacrifices the structural integrity of the skeleton in an attempt to preserve blood pH. What does that tell us about the profound, systemic, long-term consequences of an uncorrected metabolic imbalance, even if the immediate pH value doesn't look catastrophically abnormal? It really emphasizes why identifying and treating the underlying cause, not just chasing the numbers, is so fundamentally important.
That is a powerful thought indeed. The hidden costs of imbalance. We hope this extremely detailed deep dive has illuminated the intricate and often challenging world of acid-base balance and its disturbances, providing you with the knowledge and systematic approach to tackle this topic with confidence and deep insight. Keep exploring this fundamental aspect of human physiology.